morning, everyone. Welcome back on IWEEK 2022. Good morning from Indonesia, Dr. Jude Bayham.
Good morning. Thank you.
Morning. So before we would like to proceed to this session, I would like to introduce our speaker, Associate Professor Jude Bayham. He is currently the Associate Professor from Department of Agricultural and Resource Economics, Colorado State University. He earned his Ph.D. in Economics from Washington State University, Master of Science in Applied Economics from University of Idaho, and Bachelor in Economics from California State University. Okay, so without further ado, Dr. Jude Bayham, you may proceed to deliver your presentation. Thank you.
All right, well, thank you. Well, thank you very much. It's a pleasure to be here. I wish I was there, but I guess this is the next best thing. So today I'm gonna talk really about policies during COVID and potentially beyond as we move into a world where COVID is a more sort of permanent feature that we are dealing with. And really, I'm going to focus on the lessons that I've learned from Colorado, and I'll talk a little bit about where that perspective is coming from. So the moderator did a nice job introducing my background. I put it on a map for you, just in case you're not familiar with some of these places in the U.S. Chico is a town I grew up in Northern California, and my father was a professor there, and I went to school there as well. And then I went to University of Idaho for a master's and studied energy economics, and then I did my PhD at Washington State in natural resource economics and focused on wildfire management in the West, which is a big issue in the United States and throughout the world, but in different ways in different places. And then after that, I got a postdoctoral research position at Yale, and that's really where my work on infectious disease started. I like to say that I got the job because I had experience with wildfire and disease spreads like wildfire. But in any case, I spent time, 2 years at Yale, working on integrating behavior into infectious disease models. And that's really what I'll be talking about today. After that, I actually got a job at Chico State. That was my first faculty position. And I was there for a couple of years. And then in 2017, moved to Colorado State, which is where I am today and where I'm talking to you from, in Fort Collins, Colorado. Really smack dab in the middle of the country. Okay, so without further ado, let's get into it. I felt like I should start, talking about the COVID-19 pandemic and just give an overview of some of the global data on Indonesia and some of the neighbors in Southeast Asia. And so, I'm sure you are all familiar with some of these graphics. On the top panel here, we can see cases. And then on the bottom panel is deaths, both in per million. So normalized so that they can be compared. And I tried to keep it fairly with few lines on the screen, so we could look at the overview and some of the statistics on the left hand side. What I think is striking is that there aren't the early waves that we experienced in the United States that don't show up as strong in Southeast Asia, but the more recent waves certainly do. And you can obviously add more comparators there compared to Singapore and Vietnam. But I think what's most striking is when we add the US. to this comparison. You almost can't see the lines for Indonesia, at least in the cases, and I'm sure there's many reasons for that. And then maybe until recently, the impact in terms of deaths has not been near as dramatic, and so one of the normalized statistics we can look at that adjusts for population is the share, so the one in how many number of population has died from COVID, and you can see that the rate in the United States is just so much higher. And so really what I'm going to speak to today is really my experience doing research on infectious disease and how economics can play a role in infectious disease research, and then also my experience as an advisor to the government of Colorado, to the state of Colorado. And I'll speak a little bit about certain projects that I've worked on or questions that I've worked on. And really my talk is going to focus on three things, three major themes. That human behavior plays an important role in modeling and studying pandemics, that estimating the effect of policy during a global pandemic is essential, so it's really important, but it's also really challenging. And I want to talk about how me and my team have dealt with that challenge throughout the pandemic. And then lastly, that because this is a course dealing with economics, talk about public health versus the economy, and really why I think that this is a false dichotomy, that it's not an either or, and I'll hopefully explain what that means. So I want to start with some background, a term that my broader research group and I have adopted for a while, that's economic epidemiology. So economists study how people make decisions when faced with trade-offs. Some decisions can carry risk of negative outcomes, right? We often talk about lotteries or things like that to think about risk. But one possible negative outcome could be communicable disease and contracting disease. And so economic epidemiology is an effort to integrate economic theory into epidemiological models of infectious disease. And I have some citations here and a reference list at the end of the slide deck for some papers that do a nice job explaining this. Really, the goal here is to model the people in an epidemiological model as economic actors, whose decisions then influence the spread of disease. So what does that mean? Well, I have some graphics from a paper. I promise that these are the only equations in the entire presentation. But if you'll bear with me, I think it helps clarify why thinking about behavior and economic theory in the context of disease is important. So this is a pretty standard SIR, or we're using Z instead of R in this case, but susceptible, infected, recovered. So the idea with these models is the population moves through these three compartments. These are called compartmental models, and they move through based on these equations of motion. So what this term is essentially saying is people leave the susceptible class as they're infected, as susceptible individuals interact with infectious individuals at some rate, beta, and they have some contact rate. And then this same term shows up right here. They enter into this infectious state, potentially infecting other people, and then they move out of that state into a recovered state. And you can have lots of variations on this model, but the most simple versions of these models don't have this C term. And this C term we can think about as contacts, right? And if you think about the economic agents or the population making decisions, as you go about your day, you're not randomly bumping into people. And this model was originally adapted from physics to model particles essentially randomly bumping into each other. And so what economics can add to this is this idea that we aren't just particles randomly bumping into each other, we're making decisions. And so if you think about modeling that C term, this contact rate, this is a dynamic program. We can think about maximizing utility, so a familiar economic concept, and a forward-looking agent would look at their utility today, plus some discounted stream of benefits that they're going to get in the future from either remaining susceptible with some probability 1 minus p, or contracting infection with some probability p. And so the idea here is you can solve this dynamic program for some optimal choice of contact C. And when you do that and actually build that into this epidemiological model, we can generate or simulate curves that look very different from the basic epidemiological model. So this is without any what we would call avoidance behavior, people changing that contact rate as the risk of infection increases. And this solid line shows actually what it would look like. So the intuition here is that as prevalence increases, that's what's on this vertical axis. So the fraction of the population that's infected at any given point in time, as that increases, it affects this calculation. People, especially if more risk-averse people, might change their contact rates, and by doing so, that has the effect of flattening out this curve and reduces that peak. And there's no policy or anything here. This is what we would call endogenous response or voluntary response. And so this phenomenon has obviously been worked out in theory, and this paper was published in PNAS, Proceedings in the National Academy of Science in 2011. And this model has since been adapted to the COVID setting more recently. But the key question here is, sure, we can write a theoretical model down, but is there any empirical evidence for voluntary response? And so from about 2011, when that paper was published, until more recently, we've been working on papers documenting empirical evidence for this. So this is one by Fenichel et al. In 2013 in PLOS One, looking at whether people voluntarily didn't get on flights to Mexico during the 2009 swine flu. Until the COVID pandemic, this was one of the more recent disease outbreaks that we experienced in North America, at least. And so what these authors document is, if you look at Google Trends as a measure of attention to the 2009 swine flu, you can measure the effect through regression modeling of essentially missed flights. And they find that a pretty small fraction of missed flights were attributed to disease risk. So it was some limited evidence. Another paper in 2015 studies the similar swine flu outbreak, but instead uses TV watching as a proxy for time spent at home. The idea being you view going out, interacting in public as a more risky activity, so you're going to stay home and watch TV instead. And this basically shows during this period that TV watching increased above its sort of average at that period in time, and so we took that as evidence of avoidance behavior or behavioral response. In another paper that I led in 2015, we used the American Time Use Survey, which is a ongoing survey that the U.S. government has been running since 2003, actually, and we use that data. So it's a minute by minute time diary. How did you spend 24 hours of your day? where did you go, what kinds of activities did you do? And through a method of looking at where people are at any given point in time, we can construct these contact matrices. So individuals interacting with population by age groups. And so in this, these are contacts at home, and this is a pretty familiar figure to a lot of disease epidemiologists. You would see contacts between parents and children here at home, and then also people that tend to be the same age. In public, the contact structure looks very different. People sort of in workplaces, the 20 to 60 in the US, that's, sort of the working age. You get a lot of very diffuse contacts there, and then a lot of concentrated contacts between children at school. When you add those two together, you see this feature where a lot of contacts of people within the same age, and then again the parents and children. And so what we did is construct these contact matrices during the outbreak period, so April through December, but instead of just in 2009, we did it for every single year. And then we simulated epidemics based on those contact patterns that we observed from data in each of those years. And we also did so before the outbreak, so January through April, and simulated the swine flu outbreak. And what we find is that if you took 2009 in the pre-outbreak period, there's really no difference. I mean, there's certainly variation here, but it looks just like its neighboring years. Whereas if you look during the outbreak, it's a lot lower. And so we interpreted this along with some regression results as avoidance behavior. Okay, so you might also be asking yourself now, this is great, but why does it really matter if people alter their contact patterns? Well, it can matter for two reasons. It can mask estimation of the true epidemiological parameters, so how transmissible a disease is or a virus is. And the feature we've focused more on is that it can lead to the misattribution of policy. So if you implement a policy when people are going to change their behavior, you might look at the data, what happens after, and say, oh, this was great. We actually the policy worked, but you'll never know if people instead would have taken some of that protective behavior on their own. And so when the COVID pandemic began, obviously it was unfortunate, and I have young children, and I was concerned about my family's health, but at the same time, it was an opportunity to study a pandemic unfolding in real time. And so Jude Bayham led this study, and I was a co-author on it, and we eventually published it in Proceedings of the National Academy of Science in 2021. And really, we were asking the question, can we disentangle the effect of voluntary behavior, what I was describing in that previous theory, from the effect of policy? Obviously, all over the world, policies were implemented. And so we are really asking the question of, can we separate these two things? Can we understand the role of policy versus this voluntary behavior? Unfortunately, the answer is not completely. But we thought that we could say something useful here. So what you're looking at here is a map of the US, colored by the darker purpler colors are the date on which the stay-at-home orders were implemented in the US, and these were done at the county level, which is why you see some darker colors in Texas. These are around some of the populated areas. And then all the way up to the lighter colors in April. These were the latest states to adopt. And then the states with white never implemented a statewide stay-at-home order. And what we did is look at this implementation relative to time at home, and from mobile device data or cell phone data. We were able to acquire cell phone data for people all over the US. and they were measuring the amount of time that that device stayed at home on that day. And so these panels here are just summarizing that data. And one of the key things we can see is that this is normalized to the day relative to the first county case reported. So the first case reported in the county, and it's pretty clear that people were starting to spend more time at home even before the policy was implemented. This panel down here on the right shows the stay-at-home policy, and again, that effect is pretty clear. The blue line is the without the places or people in counties that never experienced the stay-at-home order, and the black line is those that did experience the stay-at-home order. So the blue lines, if people were strictly behaving according to the policy, the blue lines wouldn't have changed at all, right? They would have stayed exactly where they were before, but because we see that blue line changing, that's one bit of evidence that people were responding. Plus, we see that response starting well before the policy was implemented. So the way we presented these results and tried to provide some policy relevant, sort of actionable information is to look at that voluntary effect and then add on what the policy effect would be, and to calculate what the equivalence would need to be to induce that same voluntary effect. So what we find is both policy and voluntary response are reduced transmission, and so we're meaningful, but and the way you can think about policy is it is like having more and more cases in the county. So it's like accelerating through sort of letting the epidemic go, and why that might be important is in many cases the policy was to reduce or limit the strain on hospital capacity. And so here we find that these yellow counties across the US benefited a lot from implementing a policy. They avoided a lot more cases. Okay, so now I want to shift from sort of the some of the research we were doing and some of the theoretical work to putting research into practice. And this is really what I've spent a lot of time on over the past couple of years. So I've been part of the Colorado COVID modeling team. That's an active link. You can see we produce a lot of public reports. Our team was assembled to advise the public health department in Colorado and also the governor's office. We build and have updated an epidemiological model in order to guide policy. We review literature. We write some papers ourselves. And probably most importantly, we have held weekly briefings with the governor of Colorado for almost 2 years. And we write reports and speak to reporters about our findings or about what we expect might be coming. And really what's been unique about this experience is it's required a lot of fast-paced research with very strict deadlines. So most of my work, I spend months, if not years on, but some of the questions we were asked to answer, in a couple days or a week. I really learned the importance of clear and effective communication. So that became really important, even if the analysis was not overly complicated. It was important that we communicate effectively. Projection versus prediction. So we were never trying to predict what was going to happen in the future. We were trying to look at scenarios and provide information to the people that were making decisions. So here's an example of some graphics that we would produce and present to the governor's office. This is the number of hospitalizations over time in Colorado, and we would fit our model to the number of hospitalizations more because in the early days of the pandemic, testing sites were not up everywhere, and we couldn't really trust the case data. So hospitalizations was a reliable, consistent data source. And you can see here that the model is fitting at different periods in time. We're producing the RE, the effective reproductive number, which is a summary measure of how quickly the disease is spreading. And then we would also present information, again, using that cell phone data, how many people are visiting restaurants. So we can see these red lines are 2020 versus the gray lines in 2019. And we can see during stay-at-home orders that visits to restaurants obviously fell considerably because a lot of them are closed. So this was information on the current status of the pandemic. We would also try to provide operationally relevant information. So this is the number of modeled cases. So I mentioned we fit the model to hospitalizations, but then we can back out how many cases should there be and compare it to the number of cases actually detected with surveillance systems. And so this would help the public health department understand if they needed to provide more testing to people, maybe target testing in certain areas. And because we had this model, a lot of what we were doing with it was trying to project different scenarios forward. So what if this current state of things kept going forward? Would we exceed a hospital capacity? It was almost always about this threshold. TC just stands for transmission control. It was a summary parameter in the model that could be moved up and down, could be affected by policy. And so this was just an effective communication tool. We would also answer specific questions. So again, using that cell phone data, do we expect to see a large surge of visitors from out of state? Colorado is a popular destination, both in the summer and the winter. There's a lot of big mountains here, and so people like to come here to recreate. And we can compare 2019 data and look at spikes during certain holidays to what we were starting to observe in 2020 and try to inform policy moving forward. Do we need travel restrictions? Do we need to, does the government want to implement travel restrictions? And we also looked at, did people gather for certain holidays? So Thanksgiving is a big US holiday. We were able to compare 2019 data with 2020 and show that yes, people did gather, certainly more so than regular. This is visits to other people's homes, but a lot less so than we saw in a normal year. So they're all sort of answering questions to provide situational awareness. One of the case studies I really want to focus on now is mask mandates. These have been a very politicized topic and policy in the U.S. And it was, of course, in Colorado as well. So throughout the pandemic, the Colorado governor has debated the removal of statewide mask mandates, and there actually hasn't been one for a long time. But the mask mandate was implemented in the summer of 2020, and in the spring of 2021, the governor was considering removing this mandate. And so the question was, what will happen if I remove the mask mandate? And then a corollary to that is, has the mask mandate been effective? So up till now, has it been effective? And we need to estimate the causal effect of the mask mandates on health outcomes. Really, this is what econometrics has really spent a lot of time trying to understand. And so this was a great opportunity to implement some of these ideas. The challenge, of course, just like in any policy impact question, is that we tend not to observe the counterfactual. What would have happened had we not had a mask mandate, or had we left the mask mandate in place? And I think thinking about these types of questions empirically I think it's useful to start with what's the ideal experiment. So if we could compare the observed to lots of parallel universes, obviously we cannot do this, but if we had lots of parallel universes, some of them got mask mandates and some of them didn't, then we could compare what would happen. Obviously, we can't do that in reality. And so one thing that is at least gets us part of the way there is compare Colorado to other states and try to control for some other confounders. And we use two methods to do this. Out of a more modern econometrics toolbox, difference in differences. And so that's a way to compare treated and controlled units over time using the two-way fixed effects model, but that has now got a lot of attention recently in the econometrics literature. And then another fairly novel method called synthetic control. And the idea here, and I'll talk more about these, but the idea being that you can find a subset of other states or other control units that did not receive a policy or maybe received it later, but do show similar pre-event trends. So these are places that kind of looked similar before the policy was implemented, but then after the fact, these other locations can serve as the control. So it's always useful to start by looking at the data, and it also highlights one of the challenges here. So this was a slide I presented to the governor, where we're looking at hospitalizations per 100,000 in Arizona, Colorado, and Texas. So some states that are similar size, and Texas is a lot bigger, but in similar area in the US. And one thing you can see here is that not only did these policies get implemented at different times, but some also had other policies along with them. So bar closures, movie closures, gym closures, things like that. And so, again, there are no perfect controls here. We don't have the exact parallel universe. But what we did is estimate the difference in differences model, looking at states across the US, and we find that the mask orders did reduce the log growth rate. So this was our dependent variable in the regression, and we were able to show that there are statistically significant impacts of the mask order. And I showed that TC, that transmission control, before. We had to map the results of this into something that we could implement in the model. And you can see when you add different controls, that effect size goes down a little bit, but is still negative. So as the mask mandate was implemented, those places with the mask mandate saw a lower growth rate, essentially. So this was our evidence for looking at 2020. So we were focused on a time period, April to December of 2020. We also wrote a paper, Jude Bayham led this one as well, and we were asking a slightly different question when the mask mandates were implemented. It's really a question about how might that alter people's behavior and other contacts. And so this is a phenomenon known as risk compensation. The idea being, if everyone's wearing masks, you might think that contact with other people or going to risky locations is less risky. And so we would expect to see more activity. And so we're looking here again using cell phone data. We can show that people indeed, as the mask mandate was put in place, people went out to restaurants more, as you might expect, and spent less time at home. So this is that time at home, and places that got the mask mandate spent less time at home. So again, this isn't necessarily, it's certainly not saying mask mandates were bad, and we know masks were very helpful, but that the effect of the policy might not be just the effect of the mask. It might include in it some other behavioral response. So again, just trying to implement economic thinking into understanding policies and infectious disease modeling. So the mask mandates were repealed in the spring. And in the fall of 2021, we started to see COVID rise again. So the mask mandate was lifted around here. There was a little bit of a small wave. The red line is Colorado here, by the way, and all the others are all the other states in the U.S. But in the fall of 2021, we started seeing an increase in hospitalizations again. And so the governor was asked, or was being pressured to implement a mask mandate. And he was very skeptical because mask mandates had continued to become more and more politicized, and was worried that people would not comply with the mask mandate. So the first place I always go is to look for data. And if we had new data sources at that time, which we had a public survey administered through Facebook that asked people, did they wear masks in public? And you can see during the mask mandate period, sorry, these are counties in Colorado. During the mask mandate period, the percent of people wearing masks was quite high. When that mask mandate was lifted, it fell pretty low, down to near 20%. And then over the summer, the CDC, so the US Federal Disease Control Agency, suggested that people start wearing masks again. And we did see some rebound in certain areas. This happens to be actually both of these happen to be counties that are very conservative, or very high rates of Republican votership, that have tended to be resistant to COVID policies and mask wearing. And so the governor was skeptical that people would actually comply, because when mask mandates and really most policies in the US were implemented, there wasn't much enforcement. And then that's another bigger sort of economic issue about policies that aren't enforced, aren't really policies. But what the governor charged us with a very specific question in this case. New Mexico, which is one of our neighboring states, had implemented a mask mandate in August. Now we were in the fall, in October. And so he said, well, I've been keeping an eye on New Mexico, and their cases seem to be going up and then going down like in other states. And so I thought this was a perfect setting for a synthetic control approach. So we let the model look at all of the other states, and the model picks which are the most closest states, with conditional on some other covariates, but that showed similar trends. This is the 14-day hospitalization growth rate, showed similar trends over time before the policy. And you can see over here, this is a classic output of a synthetic control model, where the estimate is the difference between the treatment and control states. So the treatment here is New Mexico, and the controls are other states in the US. And it's going to take a weighted average to create the synthetic control, the control unit. And so what you want to see in these graphics is that the pre-trends, so before the policy is implemented, you want to see this line right about 0. No difference between the other states and the soon-to-be treated state. But then after the policy is implemented, you should see a divergence. And the line gets a little bit lower, suggesting that there's a slightly lower growth rate, but the 95% confidence intervals are quite high. And so we couldn't say definitively that mask mandates were the right policy in this case. So this was a case where real-time sort of econometric techniques did influence policy making. I should note the limitations here, that ideally in these studies you want to have a completely exogenous implementation of policy. In this case, obviously, the policies were being implemented in response to the pandemic, and so they weren't random. That assignment was not random, which creates a selection bias issue. So, I think it would be tough to necessarily publish these results in claiming that they were causally identified, but in any case, this subject to those limitations, this was about as good as we could do. I picked another study that I did for the Department of Education during COVID because they used a slightly different approach here. But again, the effort was to try to get at policy impact. So the Department of Education was asked to allocate federal grant funds to areas most impacted by COVID-19. And the unit of observation here was county in the US. And so similarly, there was the need for a causal effect of COVID-19, and we were looking at employment rates. So which places were most affected by the pandemic in terms of as measured by employment. And so the approach here was to forecast the trends, the pre-COVID-19 trends, and then compare those to the observed. And the reason I chose this method is because this trend was so stable. There's some seasonality here, but employment had been on a pretty stable trend for some time. And so you can see the time series forecast model. It was an ARIMA model. Forecasted basically this trend to continue, and then we can calculate the difference across, over this period up till 2021 when I did the study, and this difference would be the impact. And so here we did this for all the counties and ranked them by the percent affected, and this criteria was used to allocate grant funds to some of these counties. Okay, so I want to get to my last point here, and then we, hopefully can have a discussion. But this last point is really that, at least in the US media, there's been a lot of conversation. It was a frequent topic of conversation early on that you could either have public health, so you could have public health interventions, restrictions, lockdowns, things like that, business closures, or you could not have those things and have people get sick, but have a healthy economy. And I talked to a lot of reporters, investigative journalism people, and really pushed back against this theory. And the idea was rooted in some of our in some of that work we had done before the pandemic. So this plot right here is just showing I've normalized these things to just be an index so we could put them all in the same graph, but this is hospitalization rate at the beginning of the pandemic. So obviously increasing. And then this is consumer spending from this website, Track the Recovery. This is from credit card data in the US. And we can see that drop pretty dramatically and then start rebounding by the summer of 2020. We can add in here business revenue. So if consumers stop spending, you would imagine that business revenue would fall. And this is again measured from business data, not tax data, but businesses that use accounting software. And then if businesses stopped earning revenue, eventually you'd expect them to have to lay people off, and so we would see employment fall. And so yes, we see all of these features, and I know this is similar trends have been observed in countries all over the world. But the ultimate question here is, what would have happened in the absence of interventions to reduce transmission? So that there were policies put in place, but what would have happened if those policies were not put in place? And that's really the impact. And so again, this is a hard question because all of our tools for estimating causal effects rely on some untreated units or some control units. We don't observe that parallel universe, right? But we can try to get glimpses of it. And so this is, now I'm borrowing graphics from Raj Chetty's group, pretty notable economist. that was collecting data throughout the whole pandemic, and noticed that spending patterns, the divergence from the pre-COVID period, look different in top quartiles than they did in bottom quartiles of the income distribution. So up here we have the dashed line is for the top income quartile in 2019, and the green dashed line is the bottom income quartile in 2019. So pretty stable as we would expect over time. And the solid lines are the 2020, corresponding curve. So we would expect in 2020, the pandemic reduces spending. This, I just overlaid the period where stay-at-home orders were pretty common in the US. And what we can see is that for the top income quartiles, spending fell by a larger amount than it did for the lower income quartiles. And then once the stay-at-home orders were lifted, the lower income quartiles, their spending rebounded almost to where it had been before, but the top income quartile did not rebound to where it was before. And what they found is this was really a function of people in more affluent areas were not returning to businesses, were not going out and spending money the same way they had before. They were saving a lot of it. And this kind of makes sense if you think about economic behavior. Low income demand tends to be less elastic because of a larger share of the budget goes to necessities. So you spend a larger fraction of your money on food and things that you need to live, food and shelter. And higher income people spend money on other things that they don't necessarily need but enjoy, and so there's some ability to change behavior there. And so you can think about this as a voluntary response, volunteering to not engage in the economy the same way they had before, and it was largely a luxury of having the ability to maybe work from home or buy your groceries and have somebody else do the shopping, have them delivered, things like that. And this was a quote I took from some of their key findings in a report, that in the long term, the only way to drive economic recovery is to invest in public health efforts that will restore consumer confidence. So really, they came to the same conclusion that I had been talking about, that the public health and the health of the economy are very linked together. You can't have one without the other. And so if, for people that advocate, oh, we shouldn't have any policies, we should just have a healthy economy, well, that really wouldn't pan out, because people wouldn't go engage in economic activity if there was a very high risk of severe disease. Now that, at least in the US, we've moved into a very different phase. Vaccines are widely available. It's largely been, this discretion has been delegated to individuals, and so we don't see the same economic restrictions. Okay, so I just want to briefly conclude with my three main points, which are: human behavior plays an important role in modeling and studying pandemics. I hope I've demonstrated that to you all. Estimating the effect of policy during a pandemic is essential, but is hard, and all the assumptions of the models are not quite met, and so understanding those limitations are important, especially when communicating the results. And then lastly, that the public health versus economic activity is a false dichotomy. You really want to maintain both, and there is some balance there, but you have to, countries and municipalities need to manage pandemics like public health outbreaks in order to maintain economic viability. All right, so I will conclude with that and say thank you to everybody for taking the time to listen to me. And I offer a discussion question here. And I wasn't sure if that was for right now. I'd be happy to take questions about anything related. Doesn't have to be this particular discussion question. For the moderator, should I just take questions or and call on people, or how should we do this?
Yes, you may lead the Q&A session.
Okay. Do you want to ask your question?
Okay. Good morning. Thank you for selecting me to start off the question process. Okay. On my side, first of all, when the pandemic started, at least majority of the people in the world, we had an agreement that considering that this was a new disease, which we didn't have a lot of information prior. Now, but however, as time went by, as a people, we learned more about COVID. And at the same time, we were able to see the inadequacies of the policy decisions that were being taken by the governments around the world. And at the same time, you understand the impact that was caused by COVID. It was not even it was not evenly distributed throughout the world. For instance, back in my home country and continent as a whole, that is Africa as a whole, we hardly suffered at all from COVID, despite of the fears that people had about COVID on impacting us negatively. Now, but however, all those models, they didn't work as expected. And the same was proven not only just in Africa, but also in other countries. And unfortunately, most governments relied using the models to justify their actions which they took. And as time went by, we saw that those models, they were way off. And unfortunately, over the past few months and weeks, even the people behind the models, they come out and they came up against the same models, saying that they were using statistics which were not justifiable, but rather they were just using them to bring fear to people in order to try to force behavior change. And therefore, at the end of the day, we can see that the impact of the policy decisions, they were much worse off than it would have been done. For instance, let's take two countries as example. Let's take the example of Sweden and Germany, or just Sweden and the rest of Europe. You know, Sweden did not go to a lockdown, and neither did Sweden mandate some COVID policies like masks and others. And in comparison to the rest of Europe, we can see that the rate of COVID was much lower in Sweden in comparison to the rest of Europe. Therefore, can we say that? Therefore, my question is: are we justified to say that the policy actions the government took, they were worse off? And that's let me use the words of President Trump, that the cure has been worse off than the disease itself. And at the moment, we're seeing that this has actually been proven to be so. That indeed the cure for COVID is worse off. It would have been better to just take the example of Sweden in Europe, or let's say South Dakota and Florida back in your own country, the US, so that even in Florida and South Dakota have proven to be much better in managing and mitigating the risk of COVID than the rest of the states in US. Thank you.
Well, thanks for your question. And yeah, I mean, it's a really important question and something that I think we're going to be studying for a long time. I think there's elements of of truth in what you were saying. And it is unfortunate. I wanted to comment quickly on researchers or modelers using the model, knowing that it's not correct in order to instill fear in people. I think that's a short run strategy that ultimately undermines credibility. And so I think that's unfortunate. You know, to your point about policies, I don't think in all cases that the policies that the cure was worse than the disease. I know in the U.S., at least in Colorado, the healthcare system was strained pretty heavily, and the efforts were always, at least in Colorado, in my discussions with our government, was to limit the likelihood that we exceeded hospital capacity, because it was known that if that occurred, that the death rate would be quite a bit higher. That people were receiving life-saving care in the hospitals, and if they weren't receiving that, then you know, the death rates could have been a lot higher, and we did see that at times in the U.S. Now, your comment about disease prevalence across the world and being a lot lower in some areas is certainly true. I don't think a lot of people, a lot of the modelers expected that, but those are the lessons that we're learning and need to learn, you know, as we move forward. So thanks for your question. Go with Jilan.
Yeah, perfect. Actually, first time that someone said my name perfectly. Anyway, first of all, thank you for your very insightful and detailed presentation. I could actually ask you about every single one of your econometric graphs, but right now I'd only like to ask about the your model for estimated infections, since I saw in the model that actual cases were way less than what was actually reported. And I would like to ask you if you think this trend was true for like maybe all countries, and that cases were actually underreported. Like, do you think that cases were underreported, or do you think that the model was maybe inaccurate? And furthermore, what does if it was underreporting, what does this mean for policies? You know, does that mean that testing needs to be more rigorous and taken more seriously? And also, lastly, since your graph was like from 2020, do you think that now, if you made a similar model today, do you think that it could be more accurate for projecting? Thank you.
Yeah, thanks. Good questions. Let me try to address them. So that image that I showed was from the model that we've maintained. I was on calls with my team today talking about it, and your interpretation is correct. The model showed that there are likely more infections than our surveillance systems were detecting. I think that was true here and around the world. I don't know ever if the model was always right. That was our best, you know, that's the model's estimate, but there are error bounds around that. There are uncertainty around parameters. So there's another version of that model where we acknowledge that uncertainty. Now, what I'll say is it doesn't always suggest that we need more surveillance. You know, often in statistics, we are sampling and we are trying to understand a population based on a sample. And so sometimes a smaller or a sample is of sufficient size. I think in a lot of places, you know, early on, there was not enough testing, but we ultimately, at least in the US, reached a point where there was quite a bit of testing or testing available. Now, I'll say that we have redone that plot in more recent periods, and during the Omicron wave in the US and probably across the world, there was so much undetected cases. And part of that also, which I meant to mention a second ago, was that not everybody manifests symptoms when they have the disease. And so if you don't have symptoms, you don't know to go get tested. If testing is not mandatory, you wouldn't necessarily know that. So I hope that addresses your question.
Yeah. Sorry, can I just have one more follow-up question? So if you think that, you know, that they're asymptomatic, then do you think that the actual number of asymptomatic cases were actually the numbers of the people not actually accounted for in the reported infections? Because so you think, okay.
I think a good number of those, certainly in the early days, were asymptomatic infections. Yeah. Now in the U.S. and I suspect in many areas of the world, we have home tests. And when people do those tests at home, they might know the results, but they'll never report it to the accounting systems. And so that's actually an issue we've been dealing with lately, is trying to understand how to interpret the data as it's changing over time.
Thank you so much.
Yeah, thank you. And sorry, I don't know, these are just on my screen in this order. I'm not trying to, I didn't see when people raised their hands, but I see Owen.
Yes, I'm here. Okay, so thank you for the opportunity and of course the great presentation. And so when talking about the COVID-19 pandemics and policy, I believe that we should also take into account the scarring effect of it. In this case, one of the most prominent scarring effect is definitely long COVID, which in the future may reduce productivity and future prospect and long-term growth. So my question is, how big is the effect of long COVID on the future growth prospect, and what can policy do about it? Thank you.
Wow, great question. And I have a very unsatisfying answer that we're still trying to understand, at least in our state, the extent of long COVID. So how many people actually are experiencing symptoms going forward. And then once we understand that, I think there'll be years of research on reduced productivity. So I think you're pointing to an area that is very ripe for research. So if it's something you're interested in, I think it's a great research question to start studying. I suspect there will be effects. Just like we've started to see the effects of, and I really didn't speak to my work on school closures, but I have a few papers on school closures, and I think we've started to see the long-term effects of lost education. And that, I think, maybe is one policy that, in retrospect, we probably would have made different decisions in a lot of cases. That, disease severity did not seem to be as large in schools. We didn't see transmission to be as high, at least in US schools. And that lost learning, I think, is an important long-term effect. You can think of it as a reduction in human capital accumulation, just like we might see productivity losses in the future. So, yeah, good question. I'm sorry. I wish I had a better answer for you.
Thank you.
Go to Ezra, too.
Yes, thank you, sir, for the great presentation and the great opportunity. Is my voice audible, sir?
Yeah, I can hear you. Thank you.
Okay. So I would like to ask few questions. Firstly, do you have any experience that your result of research does not look the same as the real condition? What usually makes research irrelevant to the society? And the second question is, do government ensure that their policies could bring human well-being from the side of psychology or mental health from the society? Thank you, sir.
Yeah, sorry. And can you repeat the first question again?
Okay.
I didn't hear part of it.
For the first question, do you have any experience that your result of research does not look the same as the real condition? What usually makes research irrelevant to the society?
Yeah, but it's a great question. I kind of feel like all of my research is wrong. But I think that's just because of some of these questions were hard. I can speak to one of my a paper I wrote in the early stages of the pandemic on the impact that school closures might have on the labor force. So in the US, the idea was that if schools were closed, that would burden a lot of people with childcare. So people often go and work, and then their kids go to school for the day. But if their children had to be home, then they would also have to be home. we obviously during that period had closures of all sorts, and so a lot of people were home for a good period of time. So where our results from that paper, this is in the Lancet Public Health, where it did not agree with reality, was it turned out that the issue was not that school closures would create a burden of childcare, which it may have to some extent, but the bigger issue was that hospitals stopped doing what we would call elective procedures, and that is a big money generating feature of hospitals. It's a product that they sell and make a lot of money on. And so when they stopped doing that and only reverted to critical care, they ended up laying off a lot of nurses and healthcare workers. And so our results, actually, we kind of saw the same effect, but for different reasons. So it didn't quite agree with reality. What usually makes research irrelevant to society is a challenging question. And I'll say that most research is, well, what would make it completely irrelevant is if it was just wrong and the methods were not done correctly. If research followed appropriate methods and process, then I think it's still useful. We can still learn, even if the predictions of some model didn't turn out to be true. We can learn that the model had some false assumptions, or that there were improvements to be made. Moving to the next question: do governments ensure that their policies could bring human well-being? I think that no, from the psychological and mental health side, no. I think there's maybe a recognition, more so of a recognition of that now. But in my experience, that was not the top priority. The top priority was, again, hospital capacity and trying to reduce transmission such that we did not exceed hospital capacity. And everything else seemed secondary to that. And I think obviously we're seeing consequences of mental health consequences now and expect them into the future. And a lot of them are probably a result of policy decisions that were made that maybe in retrospect weren't the best. So that's my brief opinion on that question.
I'm sorry, sir. So is it me?
Yeah, go ahead. Thanks.
Okay, sir. I have 3 questions, but the first question, it's actually not a question, just a confirmation. Previously, in your research, that in terms of comparison between the hospitalization, I think, for example, using the Arizona and the other control state variable, you said that you also have a control covariates in other matter. Could you explain what covariates do you use to make the comparison between the Arizona state and then the other state? Maybe that's my first, sir.
Sure. Yeah. That's a great question, and sort of gets into some of the technical details. But for the synthetic control analysis, you can condition the pre-trend, the algorithm that finds that essentially finds the most similar trend. You can condition on other covariates too, like weather. So one thing that we found early on in the US is places that would start warming and people could get outside and eat outside and interact outside, we would see transmission reduce. And so we would condition those models on weather, also similar sort of population densities. Those types of factors would help the model choose the best controls that would serve as those controls over time. Yeah.
I see, sir. Thank you. So next to my next question, it is basically regarding your quote about it is really better to invest in the public health for the long-term growth, I think, for confirmation like that. So my question about that quote is basically, I think maybe I'm wrong, this is correct or not, but I take from the Forbes article in 2020 that per capita, the US spends more on healthcare than any other OECD nation. So basically more than per person annually is around 11,000 US dollar. But US gets comparatively major return on its investment on their healthcare resource. So basically, in another manner, I see that since 2014, I think it's the life expectancy is not like other developed nation. It's a little bit downward. I think my second question is that I know that I actually did an assignment in doing using World Bank data, using just an assignment using cross-sectional data. Basically, in most of developed nation, I think I did not include US because the US has a much larger population. So maybe it's a little bit complex, but I use Europe. I think based on, I forgot is it significant or not, but the result is that a higher healthcare expenditure correlated with the increase in the life expectancy. But in terms of this Forbes article, I think the US has an inefficiency in terms of the investment in of the healthcare. This is a generalization. Do you have any opinion about that? Maybe, and I also see that in the US, the healthcare expenditure is categorized into many things, like public healthcare or maybe a research like that. Do you think what is the most important in the sector in the healthcare expenditure that make the US is actually not inefficient at using that healthcare expenditure? That's my second question. And then my third question, in your research, I think maybe you already done that. Do you already make a research about comparing? I don't know how the United system budgeting work, but I think just a hypothesis. Logically, I think the US give some fund to its states, and then those states will use the fund based on that US. So basically, its states have a specific their own of their healthcare. So do you do any research to compare whether the higher healthcare relatively percentage than other health expenditure in each states of the United States, it's actually have better results when the pandemic started? I think that's my third question. Thank you, sir.
Yeah. Well, thanks for the questions. Those are very thoughtful. I'll respond to the third question first. I am not sure if I have not done that research, and I've not seen essentially correlations between healthcare spending prior to the pandemic and COVID-19 outcomes. You're partially correct. It's a complex system of the government does provide some funding to states, and certainly during the pandemic that was the case. That there was very little federal policy. It was, and part of that was just based on the administration that we had at the time, when the pandemic started, that they made decisions to delegate that authority to states. The healthcare spending in general, though, and this ties into the second question, you're right. It's a very inefficient system. There's a lot of disagreement in the population about the type of system that we have. But because it's very privatized, a lot of that spending flows through insurance markets. In health economics, there's a large bit of literature on insurance markets and how that ties in with healthcare spending. So the short answer is no, I haven't done that analysis myself. I'm not directly aware of it. I suspect a lot of the outcomes, it just so happens that Colorado is one of the healthiest states because we have so much activity and outdoor amenities here. It's one of the reasons I wanted to move here. And so we have fared pretty well for a larger state. But I think largely it's just because of the population and the health of the population in general. And okay, so now I'm going to jump to the inefficiency that I sort of touched on that a little bit. That, yeah, because of the structure of our system being very privatized, this sort of hybrid privatized insurance-based system, it does seem like many things are very inefficient and very unequal. So if you have good insurance, often provided by your employer, and you have resources, you have wealth, you can find and get very good healthcare. If you don't, then it's more challenging. And we have a back sort of safety net system called Medicare, and it's not a very good system. And so now I'm projecting some of my opinions, but yeah, I think in general, it is very different than a lot of the rest of the world. And I think I'll say there's a large number of Americans that wished it were more like the rest of the world.
And I'm sorry, sir, maybe connected with your answer, maybe since I know that the healthcare system in the US is complex, I actually just curious, is it important to do research? I think the US is one of the interesting country in terms of microdata, since their state has so many states like that and so many population in this state. Is it, since they're complex, since their healthcare system is complex, is it a good idea to do a research comparing between the states using a microdata level in terms of the states in terms of a healthcare spending, sir, to know the effect on its COVID prevention at the first wave? Thank you, sir.
Yeah, I think it would be interesting if you were able to get the right data. So you'd have to understand like health insurance coverage. So who has what types of coverage going into the pandemic? But you know, a lot of the you know, sort of COVID-related expenditures were you know, if you went to the hospital, you may have to pay some of that from insurance, but there was a lot of federal money made available at the time. So testing, for instance, we didn't really pay for. You just showed up, and the federal government covered testing and things like that. If you had COVID and had to go to the hospital, there may have been some bill, but you'd have to understand the insurance side of things. It would be hard to just do a cross-sectional analysis, I think.
Thank you, sir. Thank you very much.
Yep. Thanks for the question. Looks like Aisha.
Okay, so thank you for the amazing lecture and the opportunity for me to ask. So my question is, I'm just wondering whether democracy have role in like molding human behavior in responding to COVID policies. Like, are there any differences between how human behavior respond to this policy effect and how people make decision and face with these trade-offs between the least democratic countries like Afghanistan, Myanmar, or North Korea, and between democratic countries? Thank you.
Yeah, it's a really good and important question, and I'm going to partially answer it, but then tie into another point that it didn't feel like it fit well within the structure of my talk, but I think it's a really important one. So thanks for your question. You know, obviously we've seen less democratic countries around the world able to manage the pandemic, you know, in terms of public health outcomes, much better than the US. You know, I showed in one of those earlier slides, we have some of the worst death rates in the world. So yes, because a pandemic is a crisis, like any other, the other crises I tend to study are wildfire events. It requires collective action, and democracies and especially in the U.S. where liberty, and freedom is a core principle. That tends to be detrimental, where a pandemic requires collective action. It requires everybody sort of on the same page and thinking about other people, and the structure of the U.S. and our history is very antithetical to that. It is very everybody gets to do what they want to do, obviously subject to laws. But what that has meant is, if certain people don't want to follow certain policies, or like masking, or even respecting rules of business owners, things like that. And so I think the COVID-19 pandemic has really shown a large weakness in U.S. democracy, if not others. I'm not necessarily advocating for any other system, but in the context of managing a pandemic, I think there are challenges that people in the U.S. didn't quite understand until experiencing it. So thanks for the question. Oh, looks like one in the chat. Yeah, okay. These are good questions. And very big questions. Yeah, I mean, so this is Syed's question of how big of a role do you think civil resistance played in hindering the effectiveness of the containment measures taken by governments around the world? Yeah, I mean, clearly it did. I just sort of spoke to the necessity of collective action. And early on in the pandemic, I think there was maybe more will of the public in general to adhere to policies and recommendations. And then I think, as we've learned that certainly the more recent strains of the virus are not quite as lethal to healthy people, especially those who've received vaccination. We've just seen a big difference in behavior, and public health agencies in general and in the U.S. I think are very focused on maintaining public health, and a crisis like this tests them to really achieve their goals, and their goals are often to maintain the viability of the healthcare system and protect the health of the population. Now, I think during this pandemic, they've also recognized that there are economic factors, there's mental health factors, and so I think their public health departments are trying to take a more holistic perspective. But yeah, I think it certainly hindered the effectiveness, in areas of the U.S. We had large protests and things like that. To the last part of your question about the lack of trust in government and the civil resistance, I think that's an interesting point. And I think the science community can own some of that for not always being transparent about how research is done, and there are always bad actors out there who are not trying to act in the public good, and that's true in the science community as well. And so I think those factors do erode trust in government. And I think the US is a great example of that. We've seen a lot of erosion in trust for the CDC and certainly officials in certain states. One of the other thoughts I had, while being a researcher trying to do science during the pandemic, and certainly in the first year, probably working more than I ever had, and had, talking to other researchers around the country, is that this was the first time where the world, I felt like, was focused on the scientific community and watching the scientific community do research as fast as they could in real time. And part of science is arguing and debating. With social media and Twitter and things like that, there were a lot of these debates were occurring in public, on TV, on social media. And a lot of those are normal debates that we usually have in conferences and places where we can talk to other researchers, and the public usually doesn't care much about it. But in this case, it was something a lot of people cared about, and they got to see the arguing going on. And I think in a lot of cases, it meant people just didn't think that scientists knew. In a lot of cases, we didn't know what was going on. We were trying to learn. So I'll leave it at that. It's like the moderator's coming up.
Okay. Thank you so much, Dr. Jude Bayham, for delivering the sessions.
Thank you.
There's,
it was a pleasure.
I think, no more questions. So we would like to close this session. Thank you so much for delivering this session. On behalf of IWEEK 2022, we would like to express our deepest gratitude for having you as one of our speakers. Would we
Great.
now
Thank you
have,
so much.
Okay, yeah. Once again, thank you so much for Dr. Jude Bayham for your valuable time.
All right. Thanks again. I really appreciate it. It was nice, and I appreciated all the questions. Thank you.